Conversations for Health, dedicated to engaging discussions with industry experts, exploring evidence-based cutting-edge research and practical tips. Our mission is to empower you with knowledge, debunk myths, and provide you with clinical insights. This podcast is provided as an educational resource for healthcare practitioners only. This podcast represents the views and opinions of the host and their guests and does not represent the views or opinions of Designs for Health, Inc. This podcast does not constitute medical advice. The statements contained in this podcast have not been evaluated by the Food and Drug Administration. Any products mentioned are not intended to diagnose, treat, cure, or prevent any disease. Now, let's embark on a journey towards optimal well-being, one conversation at a time. Here's your host, Evelyn Lambrecht.
Welcome to Conversations for Health. I'm your host, Evelyn Lambrecht, and today I'm talking to Dr. Geo Espinosa, integrative urology and men's health expert. Welcome to the show, Geo.
Evelyn, thank you so much. Pleasure to be here.
And remember, you could find the entire transcript and video of this show on our website, podcast.designsforhealth.com. Let's get into today's show. Dr. Geo Espinosa is a naturopathic functional medicine doctor and leading authority in integrative urology and men's health. He's also a board-certified acupuncturist and certified nutrition specialist. Serving as a faculty member in holistic and integrative medicine in urology at New York University Langone Health, he's also a faculty member at the Institute for Functional Medicine. A dedicated researcher and prolific writer, Dr. Geo has contributed significantly to the field with numerous scientific papers and books, including the best-selling prostate cancer book, Thrive, Don't Only Survive. He's the chief medical officer at XY Wellness and shares his knowledge through his popular website, drgeo.com, and his podcast, the Dr. Geo Podcast. So, Geo, thank you again for being here.
It's my pleasure. Thank you for inviting me.
We haven't done a show specifically on men's health, so this will be great. And I am a little nervous. I just took GABA and L-theanine in chocolate form. I was reviewing my herbal medicine notes last night on the urinary system, and I reached out to some of my male colleagues for questions. And then now I have so many questions that we could spend a whole semester going through these. So I will try to focus on some questions that we most commonly, get from practitioners. But first of all, how did you get so passionate in this field?
I always say the field chose me. I didn't choose it. So when I was doing my final years as a naturopathic doctor, as a student clinician, for some odd reason, I kept seeing a lot of men and they kept requesting to see me. So I did more prostate exams than anyone else. And at the time, I was still hesitant to specialize because, the philosophy, right? Naturopathic medicine, you don't treat diseases, you treat people. Mm-hmm. But then I kept seeing more men. And then I developed an opportunity to work with a urologist here in New York in the Upper West Side. And he was so enthusiastic to learn what I had to offer. And I was so enthusiastic to learn what he did as a medical urologist. And I just became fascinated with the urological system and even more so with the male reproductive system, things like the prostate and, testosterone as a chemical and, erections and penises and, maybe is a reflection of odd character of mine of some sort, but I became fascinated with it. And in that practice, I kept doing more and more prostate exams and really knowing what I was doing, knowing what I was looking for. And then I got the opportunity to do what I call my internship fellowship at Columbia University, Department of Urology under Aaron Katz. And I was there for 5 years and I was just immersed with all things urological, all things urology. Again, I was in the OR with some of these surgeons removing prostates and it was just fascinating. And then I was with the guy with the erectile dysfunction guy and, what he did for it. And I was, wow, this is amazing. And the guys that did TRT and, even urinary problems, I was like, this is amazing. I became immersed. And then I've been at, then I got the great opportunity to be at NYU Department of Urology now for 15 years. And, kind of took a life of its own. And I've never deviated from that focus since, although there were many times in the beginning where I thought maybe I should, just because no one knew me. And while I was employed and it was good, I still needed to kind of have my keep there in the department, and at least bring in as much as I'm worth, or my salary or something. And it wasn't the case, but I stuck to my guns, and I just became even more and more curious about the field. And here I am now, over 20 years, doing the same kind of work.
I love it. I love your enthusiasm. It's contagious. So let's talk about testosterone. Let's talk about testosterone first.
Yes.
Then prostate health, prostatitis, prostate cancer, and BPH. So first, I'd love for you to give us an overview of how and where in the body testosterone is made and where that process might get interrupted.
Great question. Partially because I have an 11-year-old son. He's soon to be 12. And you can see that he's developing some testosterone, right? But I know that it's not from his testicles yet. It's mostly from the adrenal glands. So testosterone is in men, women make it too, is made in the testicles, particularly in the Leydig cells of the testicles. And that's about 95%. About 5% or so is made in the adrenal glands. And young kids, when they're reaching when they are at their pre-puberty stage, they're making it primarily in the adrenal glands. So my son, his voice is not cracking yet. He does have some attitude. Yes, he does. He does have some attitude. But he has some hair underneath his arms and pubic hairs, and along with the attitude, you can see that, and a little bit of a little shade going up there, like which will become a mustache at some point. You can see he has some. So most of his testosterone right now is from his adrenal glands. Eventually, when he reaches puberty, then he will start making way more from his testicles and from the Leydig cells, and then you'll see even more change and growth in that. Right? I'm not looking forward to that. But yeah, that's pretty much where it's made. It's a bit of a process of making testosterone, because it starts in the brain, right? In the hypothalamic pituitary gland, where the hypothalamus creates a gonadotropin releasing hormone, stimulates the pituitary gland, and then from there you have luteinizing hormone and follicle stimulating hormone. FSH stimulates the production of sperm cells, and LH is the main contributor that attaches to receptors in the testicles, primarily in men, and stimulates the production of testosterone. And within the testicles, I don't know, we don't have to get too much into the weeds, but it's very interesting. So it stimulates the receptors there, and then there's a process until it gets to like the mitochondria for the production of testosterone to occur. So it's not as simple receptor cells, testosterone production. There's a little bit of a process there that requires certain nutrients and things to create testosterone in the Leydig cell. So we'll leave it there before we run out of time. And I definitely want to get into some possible natural solutions to helping men with testosterone or whatever urological function we'll discuss.
Yeah, absolutely. And actually, since you brought it up, what are some of those nutrients that the Leydig cells do need to make testosterone?
Very interesting. So chronic inflammation, we know that it contributes to many diseases, but it also inhibits the production of testosterone. So one of the nutrients that at least has been studied, at least there's a couple of papers on it, I should say, that recommends things like ginger. So ginger extract or ginger. So these are things that you don't think from a naturopathic perspective. Why would I give ginger for testosterone? Well, ginger actually seems to help, at least in some studies, with that. And by lowering, not directly, but by lowering inflammation. Of course, one can extrapolate and say, well, maybe curcumin, maybe other anti-inflammatories as well. Maybe, I don't know. But certainly ginger has been looked at least in one review, very good study. Another nutrient that's important for the whole process to occur in the mitochondria is actually vitamin A as well. Vitamin A helps that process occur. very tightly. So mitochondrial health, very important for many things. I think that we will all agree that mitochondrial medicine is an important thing, and across the board for many reasons, longevity, et cetera. Certainly important to have good mitochondrial health for testosterone production. And I think vitamin A and ginger are two of the things that I like to use for that specific. It's not the only thing I use, but for that particular.
Very interesting. Thank you. So when a patient comes to see you, what are the lab markers you're looking for other than total testosterone, which is likely all that they've maybe had tested, right?
That's a fabulous question, and here's why. What I'm noticing, Evelyn, is the following, right? So in a weird way, a lot of testosterone clinics, they're just looking at total testosterone, and, that's it, if your total testosterone is, I don't know, whatever. So the normal value, right, on most labs, from most labs, is about 300 nanograms per milliliter to 1,000 nanograms per milliliter, right, roughly. So if you're anywhere in between that, that's good, right? And then some people are saying, no, optimal is 600, okay? There is no good evidence. And I say this because I used to say, well, I want my patients to be between 600 and 800. The truth is that there's no good evidence to show that that is optimal. The most important thing that a man can do, I want free testosterone to be 2 to 3%. Free testosterone, period, end of story.
Okay.
Almost irrelevant to what the total is. So I have patients just recently, by the way, because I always thought, well, you need at least 350 total to get enough free. And I've seen that. I know many patients who are at 350, but they have like 2% free testosterone or more. Just saw a patient 280, a lot of free testosterone. They're not symptomatic, no libido issues, none of that, right? So I think that we need to investigate that a little bit more. But from my clinical experience, if they're not complaining about sexual issues, abnormal fatigue, cognitive decline, low libido, which most of them will not complain if they have enough free, then I'm not going to treat the total. I don't care to treat the total. If they don't have enough free total, then that's what I'm looking to do. So that's that. Then the other component is estradiol, right? So what matters is, some people say, well, high estradiol bad for men. What I would say is the ratio between total testosterone and estradiol is what we're looking for. Estradiol is a very important hormone for men as well. Obviously considered a women's hormone, but it's a very important hormone for men. It's important for cardiovascular health. It's important, Evelyn, you may not know this, but you need enough estrogen or estradiol for libido in men, not only testosterone. So men with low estradiol actually have low libido. Okay. So bone health, many things. So what you're looking for there is ratio. So I like my ratio to be around 20-1 total to estradiol, roughly. I cannot give you, if I had to write a paper on that, I don't know that I'll have good references, but some of the experts that I listen to, plus my experience, kind of dictates that. And I like just the absolute value of estradiol to be 10 to 20 nanograms per milliliter, roughly. So I'm looking more towards the ratio, but if it's as an absolute value, I'm looking between 20 and 30. Along those lines, I think the audience is going to appreciate what I'm about to say now, which is, hopefully they appreciate the whole thing. But what I'm about to say is the following. Clomiphene is oftentimes used as a drug to stimulate the production of testosterone, right? And it does that because at the hypothalamic pituitary gland, right? Just more LH. I'm sorry. Yeah, that's exactly, because it's a SERM, right? So it blocks the receptor of estrogen in the brain, and then that makes the more LH production and so forth, and then eventually lead to the testicles, and you create more testosterone. What happens in that situation is that clinically they present with, testosterone is good, 800, maybe free is okay, but estrogen is low. So they would say, yeah, my numbers look good, but I still feel like crap. And that's because, or at least their libido is still low. And that's because their estradiol levels go down too much. So aromatase inhibitors, where you try to inhibit the production of estrogen in men, and clomiphene. Clomiphene is a good drug if there's a male infertility issue along with low testosterone. But I try not to use those drugs much unless there's a male infertility issue. And I don't use a lot of aromatase inhibitors, even if the estrogen is a little bit higher than normal. I'm really looking at the ratio that should be 20 to 25 to 1, roughly. Does that make sense?
Yeah, I have so many follow-up questions.
I know. I think I just said so much that I know
okay.
There should be a lot of follow-up questions, but go ahead. I'll let you lead the way.
So does the same thing happen with giving testosterone replacement therapy, where if you're giving so much, it throws off those levels of estradiol?
Yeah, good question. Look, sometimes in some clinics, they give total testosterone and right away they give them aromatase inhibitors in some of these male clinics. I don't agree with that approach at all for the reasons that I just highlighted, that you do need you do need estrogen. Depending on how the patient is monitored on TRT, again, sometimes they're not monitored well, I see. But if they're monitored closely, then it's a matter of making the adjustment to the TRT and the dosage that's used, right? Where maybe testosterone is 900. Okay. Maybe the estradiol is, I don't know, 40. I'm okay with that ratio, actually, 900 to 40, though it may seem high. So I wouldn't treat it with aromatase inhibitors necessarily. So it all depends what happens. So once you get the testosterone in, what happens to it? Does it convert a lot to just DHT or estradiol, or it's doing what it's supposed to do, attaching to receptors, and DHT is a fine thing as well. That's the other thing that happens with testosterone. It can convert to DHT.
I want to back up one moment to the sex hormone binding globulin. You said those levels can be too high. What's the range that you look for SHGB?
The range that I look for is around 30 to 50, I believe. Sometimes I get my ranges in my head. That's why I have always a chart, but it's between 30 to 50.
Okay.
But mostly, rather than saying, well, the SHBG is such, I'm really looking at free testosterone, and I let that dictate how much, how low I like my SHBG to be.
Gotcha. And then you just mentioned DHT, which stands for dihydrotestosterone, right?
Yes.
And what is the benefit of measuring that, and in what clinical situations, would you want to lower that? How do you use DHT?
There's some things that are a little bit controversial in medicine, of course. And one of them is, this fear of DHT because it will increase the size of the prostate, right? So DHT is a much more powerful androgen than testosterone, right? So it attaches to the receptors a whole lot stronger, and it kind of sticks to that receptor a longer than just testosterone. So it's known for things like baldness and, prostate enlargement. The problem is when the DHT is way much higher than testosterone, and that ratio is also off. It's a ratio that I like to be 12 to 1, total testosterone to DHT. When that's in balance because there's too much 5-alpha reductase enzyme activity, that's the enzyme that converts testosterone to DHT, then there's a lot of conversion. DHT goes up really high. I don't treat, so the group of drugs that are available are called 5-alpha reductase inhibitors. These are like finasteride and dutasteride. They're, again, another set of drugs that I never prescribe. I think these drugs can do more harm than good. Some people take it in the form of propecia, which is a lower dosage for hair, just keeping hair. And I've just seen too many feminization of men where they lose their libido and all kinds of things. Sometimes it leads to, finasteride syndrome, where they have these side effects, even depression, where they can FPS, finasteride, post-finasteride syndrome. I think I'm
Hmm.
close. Where they have fatigue and they don't feel well and they don't have libido and so on. So that happens about 1% of the population that takes these drugs. So summary, I don't lower DHT is not necessarily the evil hormone, just like many things are not evil. I mean, just like cortisol is not always evil, right? You need cortisol. It all depends on the numbers and ratios. Same thing with DHT. And I don't, and so that group of drugs, 5-alpha reductase inhibitors, I'm not, I don't think that's a good idea for most men.
So what about when you do see saw palmetto in a formula prostate? Will that help?
Yeah. So the question that we're trying to address is, how do we reduce DHT naturally for purposes where the DHT is too high? If the purpose is to decrease DHT, now I'm not saying DHT is bad for the prostate. I'm not saying this whole notion that let's just reduce DHT to reduce the size of the prostate. That's another approach. That's not the right approach. That's what's done medically, but I don't recommend these drugs for urinary problems related to the prostate. Right? To promote prostate health, yeah, saw palmetto in a formula is fantastic. No problem. To lower DHT, if that is the goal, then I would recommend just a standalone saw palmetto at a higher dosage.
Gotcha. Good to know. And we will get into some of those other prostate things a little later on. I do have more questions about, testosterone metabolism. So I know more about estrogen metabolism in women and using things like DIM and calcium D-glucarate and sulforaphane, et cetera. I just don't know as much about testosterone metabolism. So are you measuring that also? And were you saying earlier that you don't use things like DIM and chrysin, or you do?
Right.
In men.
So I use DIM and chrysin, or I would use DIM and chrysin if the estrogen levels are too high. So okay. I'm not trying to super metabolize testosterone. That takes care of itself in men. You have enough high, it's good. You have enough free, it's good. We don't have to worry about that. I've never seen a scenario where, wow, there's just way too much free testosterone. We need to lower this. That's, it's different than too much testosterone in women, for example, or too much estrogen in men. If there is a case where they're not metabolizing the estradiol, then DIM and chrysin is perfect to prescribe there.
Gotcha. You also said something interesting about the drug to testosterone and that it helps with infertility. And when it comes to testosterone replacement therapy, I thought that can impact fertility because it reduces sperm production. So can you talk about how those are different?
If the goal is that the person wants to increase their testosterone and also increase their free testosterone, and they have no intentions of being fertile or having kids, then TRT, it's a fine approach in most men. In a situation where they are interested in fertility, then TRT is not what you want. You want clomiphene in that scenario. And you have to be aware that the libido may not be optimal, but it may help with fertility. Why? Because it is also, remember, so it's working in the hypothalamic area and is increasing not only LH, but FSH. And with more FSH, you make more sperm cells. So that's the reason why. So you get a twofer, right? You get more testosterone, but you also get more follicle stimulating hormone production, which helps with sperm cell production. So that's why it's a drug of choice when drugs when medical approach is the way that they choose.
This is really interesting because I really feel like testosterone replacement therapy is gaining popularity, especially among younger and younger men. And I think maybe,
that's right,
I don't know, they're not aware of some of those risks. Are there other negative potential effects?
No, I just wanted to confirm what you just said, that a lot of younger men are not looking at the bigger picture. They just want whatever they want. They want more muscles, or they're trying to feel more manly or whatever. I mean, if you get off TRT, can you become fertile? Yes. But then you're going to go to a dip, right? Until your body's able to produce it on its own. And there's a way of transitioning with the use of HCG to stimulate the cells. So sometimes what they do, there's some, and I don't have this level of experience, but what some practitioners do is they do TRT with ACG simultaneously so that you can still produce enough testosterone from the testicles as well as the TRT having that benefit. So the SHG acts like luteinizing hormone, like LH, and stimulates the cells, the receptors of the Leydig cells to produce testosterone. So that's the approach that some take for fertility.
Is there also any risk or any other risks, like, with prostate cancer, we give androgen deprivation therapy, right? I don't know if that's always the case, but so is there some kind of negative effect with actually taking testosterone down the road?
Now you're asking the zillion-dollar question, and I'm going to try to answer that as simply and as efficiently as possible, because that alone, it's been a very controversial scenario. The way I would answer it is like this, and it's very important that the practitioner knows this. By the way, I'm not promoting TRT or against it. I am promoting optimal male hormones, male hormone levels. That's what I'm promoting, whether the natural approach, which can work very well, or TRT. Okay, so let's start there. Number two, having optimal hormone levels, despite it being TRT or just naturally, does not cause prostate cancer. So the practitioner does not need to worry about optimal hormone levels, male hormones, and prostate cancer development.
Great.
And that is even despite if there's a family history of prostate cancer. That doesn't mean that person will not develop prostate cancer. They might, but it's not connected. Even after a person is diagnosed with prostate cancer, then depending on their situation, some of them go on TRT. If it's low risk, if it's well managed, if it's treated and properly managed, they go on TRT successfully. And there's research and data to support that. The people that go on androgen deprivation therapy are those with very advanced disease. And I tell you, the notion of androgen deprivation therapy as a treatment for prostate cancer is very controversial. And there is some technology available now, including some artificial intelligence technology that helps the practitioner to decide if the patient will benefit from androgen deprivation therapy or not from an advanced prostate cancer scenario. So, prostate cancer testosterone treatment or optimal testosterone levels before prostate cancer, diagnosis not associated. After treatment for prostate cancer, we still want optimal testosterone levels. In men with advanced prostate cancer, the treatment is ADT. Controversial a little bit, but it seems to be helpful in some cases. And it's not the testosterone, it's the androgen receptors that seem to, in some cases, it seems to signal the development and progression of prostate cancer. So it's not testosterone, it's the receptors. So the idea is if you take away the testosterone, there's no receptors. That's the idea. I think that area is going to develop and it's going to go in a different direction, including, and this is research out of Hopkins, including using testosterone therapy at very high dosages along with androgen deprivation therapy. It's called bipolar androgen therapy. And to kind of, so what that would do is not have as many receptors develop. just enough receptors, but not. So now the androgen deprivation therapy can actually work. So high levels of testosterone will actually help. Not only does the man feel good, but it may help the ADT done simultaneously, ironically, to have regression of prostate cancer. That's not available yet for clinical use, a clinical approach, but they're studying it. So
very interesting. Thank you for that thorough answer. Really appreciate that. Before we fully move on to prostate cancer, I do have one other question, or kind of a series of questions about testosterone, but ways to boost testosterone naturally, maybe some lifestyle measures, and then some nutraceuticals. I know we see ingredients like tribulus, tonkadale, horny goatweed, things like that. Can you address some of those?
Yeah, those horny goats, I tell you.
What a name, right?
So tonkadale, ashwagandha, and fenugreek seem to be my top 3 for testosterone production. Once again, very specific for that function. The way a naturopath or a functional medicine doctor would function is that I don't think I need direct research to show this helps with that. Again, I use ginger. I use vitamin A, right? So I just want to make, I use ashwagandha. The benefit there is that it can reduce too much cortisol, right? Cortisol interferes with production of testosterone. So that combination is really, really useful. So there's lifestyle things as well. But those are the botanicals. I would add zinc to that. I would add boron to that combination, and magnesium.
Great. And then just a few lifestyle factors, just really quick.
Lifestyle factors. By the way, you can increase testosterone by 300 points or so. I've looked at it. I've studied it. I've had some data on that. So clinical data. So naturally, but it does require, it's not, some people just want the injection and keep it moving. It does require a little bit of work. Mm-hmm. So maybe sleep a little better, because sleep is, so you make most of your testosterone from you in REM sleep, right? Stage 4. So if you don't hit REM, it's going to be a little bit more difficult. So that's that. So sleep is important, right? Or at least hitting REM. Not necessarily you have to sleep 9 hours a day, but are you hitting REM? Sometimes some people can reach that, in 5 hours. I'm not so. So you got to hit REM. Exercising, you have to lift weights, and you have to focus on bigger muscles like your back and legs, and a lower extremity, that is, right? So there's no, and you find a way. I don't know. I post some of the exercises on social media and that I do, and be careful with your back. Oh my God, you got to break your back. So there's a lot of things like that may or may not be true. Bottom line is, then find a way of working out your legs that are safer, whatever that is. Your lower extremities, that is but that's important for that. And I'll tell you how that works. Is I've looked at it, and one of the thought leaders in testosterone, I remember him tweeting, he says, what he tweeted, something that said, to be clear, exercise does not help increase testosterone. I said, oh, shoot. So I need to look into this. Like, here I am saying, do this. And so that was a very general statement. What kind of exercise? What's the prescription, right? So I'm like, there's probably a prescriptive approach, right? So here's the deal. Weight lifting, and I didn't say this when we were talking about how testosterone works, but maybe I'll say it now. Not only do you need that pathway to occur smoothly, right? So, from the brain, the hypothalamic gonadal axis needs to work smoothly, but also the receptors need to be healthy, and you need enough receptors. Receptors are very important. And sometimes that's another thing, you see men with high testosterone and all the levels are fine, but I don't feel receptors. Now, there's no clinical way of measuring receptors that I know of anyway, right? The only way is through biopsy and things, that no one's going to do that. But one can assume if all things are not, if all things look good and they're still feeling a certain way, with hypogonadal, then maybe the receptors. So the way weight-resistant exercise works is by stimulating these receptors, partially. let's just say you lift weights and you do arms and you do any weightlifting. In order to increase the actual production of testosterone, then now you have to be a little bit more specific to back and lower extremities, like bigger muscles. And it's somewhere like, somewhere like 10 repetitions and 2-minute rests times 6. Like there is some research to indicate that if you do something similar to that, then testosterone does go up, not only initially, but at least within 24 hours as well. So summary, exercise, how it works is both. Androgen receptors, they get healthier, you make better, and total testosterone goes up.
Awesome. Thank you for that. And I love that you're sharing the nuances on or around these different topics too. So let's dive a little bit more into prostate cancer. Prostate cancer is the second leading cause of cancer death in American men after lung cancer. And I found this interesting too. After that, double the risk, they also tend to get diagnosed younger, and it tends to be more aggressive. So it is a major issue. I'd love to talk about both how you support cancer patients, but also about diagnosis. So first, let's talk about some of the controversy around PSA, or prostate-specific antigen. Is that the gold standard for testing?
Sure. So I have a podcast and I've written things on this extensively. People want to go into a deeper dive on drgeo.com and everything related. So thank you. I'm going to say this in bullet point form. PSA is a good biomarker for prostate health, for the prostate itself. PSA is a decent biomarker for prostate cancer as well. So decent, what does that mean? I mean, is it good or not? Well, it's decent. If somebody comes in with a PSA of 50, 100, they have prostate cancer. I know that. So there's some value there. I mean, I don't even they don't even need a biopsy, right? The trick is when the PSA is a little bit elevated, because the range that they give you in the labs really don't matter. That 0 to 4 range that they give you in labs, that doesn't matter. Somebody can have a PSA of 2 and they have prostate cancer. Somebody can have a PSA of 20. And what they have is a big prostate. They don't have prostate cancer. And I see many of those men, right? But it's decent. Now, only about 10% of men walking around the world have high PSA. Like very high PSA, if I look at just my practice, I say, yeah, PSA, it's always high in men and should always be high because, no, that's my practice. This is what I do. I see a lot of PSA tests. But if I get out of my practice, which is homogenous, only about 10% of men walking around the world have a high PSA to start with. Most men, 90%, have a low PSA. Low meaning what? Depends on their age, right? Remember, the range doesn't matter. But if they're 40 years old, it should be less than 1. If they're 50 years old, I don't know. They should be, between 1 and 2. I'm kind of pulling these numbers out of the air a little bit. If they're 60, 70 years old and they have a PSA of 5 or 6, I'm not thinking necessarily, oh my God, they have prostate cancer. And that's above the upper range of 4, right? So it depends. The other thing that PSA helps is also velocity helps. So what does that mean? If PSA changes, that PSA kinetics change, where PSA rises within a year. So you take 4 PSAs a year, one quarterly, and PSA rises 1 or 2 points every single time, then that PSA velocity to me is like, ooh, I need to look into this. I don't like the velocity. That shouldn't happen. So PSA has some value. The other thing that has value is called PSA density. PSA density is when you take the PSA value and you divide it over the PSA volume, which you only can really get from either an ultrasound or an MRI. So it tells you the size of the prostate. And if the PSA density is above 0.15, then that indicates the possibility of prostate cancer. But this is yet another way of using PSA that's valuable. Okay, so there's that. That's the PSA story. It's good, but only if you use it properly. It's not like biopsy right away if it's X number. No, unless it's like 50, like I said, or 30, or then these are very high numbers. I don't care what age you are. But 0 to 10, 0 to 20 in older men may not be, it could be just from because there's a lot of benign reasons why the body not only makes PSA, but it seeps into the bloodstream. So I think that's the PSA story. The reason why you're asking the question and the reason why people are confused, Evelyn, is because in the early 2010 or so, the United States Preventative Task Force said no more use a PSA to screen for prostate cancer, period. And the reason for that is because too many people were biopsied when they had a high PSA and they didn't need to, or too many treatments for prostate cancer in cases where they had low indolent prostate cancer and they would never die from it. So over-treatment caused that to happen. But what happened there is that now more people that came into the office with prostate cancer, now they had more aggressive prostate cancer. So no, there's PSA value. Then the United States Preventative Task Force changed their tune. So, well, no, now it's category C, which means is a decision between the doctor and the patient. And that's where we are with PSA. There are other better tests that are more specific to prostate cancer that uses PSA, but in some sort of algorithm that uses other what's called kallikreins, right? Kallikreins are a type of protein, and there's 9 of them. PSA is kallikrein 2 is one of them, and then they use 3 others. So this one test called a 4K score. It's pretty good. It's a blood test. There's another one called IsoPSA. Another one, again, a little bit more sensitive to prostate cancer and specific to prostate cancer than just PSA alone. But if we're saying that PSA is a problem, then sometimes I see a guy with a high PSA. Now this PSA kallikrein 2 is using the algorithm, and now the 4K score is high. Is that a real number? Or then that's the question. There's another test, is a urine test called exosome DX test, and that's a urine test that does not use PSA. And I find that test to be useful. It's easy to do. You don't have to do a prostate exam or massage before urinating in a cup, and they just pee in a cup, send it away, and that's useful. The other test is Select MDX. Once again, urine test. You do in office. You do need to massage the prostate, and then they pee in a cup and they send it away. That's also, they don't use PSA in that scenario. Also good. So that's the PSA story in a nutshell. No pun intended.
Thank you. So if a practitioner is maybe not necessarily specializing in men's health, but they do see men in their practice, do you screen everybody like over the age of 60 for it? Or are there other indications that would make you think, okay, I need to get them checked for prostate cancer and run some of these tests?
I screen everyone. And again, I think this is separate. The guidelines, AUA guidelines, and the organizations that are providing guidelines to practitioners suggest, start PSA testing at 50 and stop at 70. Right? So somewhere between 50 to 70, that's when you start. I disagree wholeheartedly. I think that men should start getting their PSA tests at 40. I see too many men in their 40s. I mean, a low percentage, but it's not zero, with aggressive prostate cancer. And in fact, what I'm noticing clinically is that when men in their 40s present with prostate cancer, oftentimes it is more aggressive than the older man. So I want to start everyone at 40. And I want to start everyone at 40, period. Definitely if they have a BRCA2 gene mutation or a very strong family history or African American or all of the above. Start at 40. At minimum, you have a baseline. Okay, so if the PSA rises 2 years, at least I have a baseline. I know that at 40 it was 0 or was low. So no harm, no foul starting at 40. And perhaps depending if they do have a genetic predisposition or a family history of prostate cancer, then I'll test their PSA once a year, throughout their 40s. If it's a little bit elevated, I'll check it every 6 months. So there's value with PSA once again, because you see the velocity and changes.
Right. Are there some things that we can do to prevent prostate cancer that you use with your patients?
There's one story that says, look, all you need to have is a prostate and live long enough, and you're going to get prostate cancer of some sort, right? And then there's the other element that, well, we do some of the right things, we lower the risk. So who's right, who's wrong? Maybe everybody's right. There could be two rights. And the most important thing is, even if you develop prostate cancer, is not to develop the most aggressive type, because most men die with prostate cancer, not from it. So the way you lower the risk is based on evidence and my experience. Again, that's a whole long story. But if I can hit the audience with some takeaways, is the following: you try to create a microenvironment that's hostile to prostate tumors growth and development. And that environment, it may overlap with other cancers to some degree, but what I know is prostate cancer is the only oncology that I work in. I'm pausing because the dietary approach is so controversial. It is insane. So what most people read and think, and a lot of the data suggests that a plant-based diet is the way to go. I don't disagree with that, except that I don't define a plant-based diet by excluding animal products. That's not my definition of it. And as it relates to red meat, people want to, get emails and things. Well, the evidence shows that meat is, promotes prostate cancer. All right, show me the evidence. The evidence shows, and this is systemic review and meta-analyses show that there is no association with red meat. And I forget about grass-fed and all that. That's different because they're not looking at that. But there is some association with meats that are cooked in high heat. So there's something there. Some of these heterocyclic amines, and some of the processed meats, hot dogs and sausages and things. There is some association there, but not red meat, and certainly not red meat when somebody's eating a healthy diet with red meat. So my approach, Evelyn, dietarily is the following. I'm not trying to change who you are. You want to be plant-based, vegan plant-based? Great. Let's figure out what's the best way of doing that, because God knows I probably have seen way more unhealthy vegans than I've seen meat eaters. So let's just figure out a way to do this properly to help your prostate cancer scenario, and B, to get enough protein in, because you still need muscle and things so that you can live long enough and be healthy. Those are the two things dietarily. Exercise, I really ask them to give me 4 to 6 hours a week of moderate to high intensity, even some mild, just movement, neat, right? Some just regular movement is walking. So full spectrum. But in terms of moderate to high intensity, I do ask them to give me about 3 hours a week of moderate to high intensity. And there's some evidence to show that that helps men reduce the risk of prostate cancer, and less men die from prostate cancer after they've been diagnosed. From a nutraceutical perspective, I tend to use quite a bit of curcumin. But inflammatone is a great product.
I love inflammatone.
Okay. Yeah. So I would use something, I have, we know, I have my own formulations, but I still use inflammatone in more aggressive cases, actually. So I still use it, even though there's formulations that I'm affiliated with. So inflammatone, go to, great formula. I remember before I did my own thing, in general, I used to do 4 to 5 pills twice a day. I felt if they can tolerate a lot of curcumin and things, so sometimes I get GI distress. Okay. Broccoli extract. Again, I'll promote Broccoli Protect, I believe is what it's called. I mean, here I am. I mean, all the time. Some sort of good quality broccoli extract, because if the goal, based on evidence, the crucifers have all the chemicals, the plant chemicals that seem to have anti-prostate cancer properties. So I'll have them eat a lot of those, and let that be the primary vegetable. and then take that in supplement form. So things like green tea extract as well, quercetin is very good. Anything that can stimulate or modulate the immune system. So things like magnolia bark and andrographis are fantastic. Okay, essentially anything that does one of 3 or 4 things: reduce chronic inflammation, so your NF-kappa Bs and all these things, protect against oxidative stress, helps detoxification. The liver is a very important organ, or just detoxify. Again, the Science for Health has many of those as well. Milk thistle and those that helps the phase 1, phase 2 pathways, and some things that seem to have some level of anti-cancer properties in some way or another. And immunomodulating. I think I said that. Magnolia and andrographis. Yeah. So that's what I'm trying to do. I'm trying to help so you do this with good diet and so forth. And sometimes you're trying to also, depending if they're on ADT, limit some of those side effects from the ADT. So in that scenario, I want to help them with cognition, bone health, because without testosterone, the bones, they become more either osteopenia or
osteoporotic,
osteosporosis. So other than weight resistant exercise, which again is key in that scenario, things like boron. I don't do a lot of calcium in my patients because I just think that sometimes they overdo it and it becomes more of a problem. But I do magnesium, boron. Bacopa is an excellent botanical for cognition. Acetyl L-carnitine, again, for cognition and even cardiovascular. Huperzine A and things like that, and lion's mane, things like that, to help them with cognition. While they're on ADT. Ashwagandha, again, great. Question is then, will ashwagandha, while I'm on ADT, counteract the ADT? Impossible. The ADT is way too strong. I think there's way more benefit for taking ashwagandha when men on ADT than downside. And it helps them with fatigue. So, and I do off-label recommend black cohosh in men on ADT. So they get less hot flashes and night sweats like women do postmenopause.
And it's an anti-inflammatory, right?
Anti-inflammatory and good for bone health also. I don't think it's gender specific. Yeah. For any of those benefits, actually.
Yeah. Thank you for such a thorough answer and so many clinical pearls in that. We haven't even talked about prostatitis and benign prostatic hyperplasia, which are a lot more common than prostate cancer. And I don't know if the statistic that I have here is right, but 50% of men do get BPH or benign prostatic hyperplasia. So I want to talk about that. And prostatitis is just inflammation of the prostate, right? What's the difference between that and BPH?
It's a little bit different. So inflammation is literally inflammation, right? So it's inflammatory scenarios when now the cells, not more cells are growing, but the cells are inflamed, right, from these inflammatory chemicals. So these one cells, they grow. Hyperplasia is duplication, excessive duplication of these cells. So there's too much production of these prostate cells. So a little bit of a nuance there. But sometimes, here's what I've seen. In patients that I've seen maybe, I don't know, thousands of biopsies of the prostate, and almost always, even if they don't have prostate cancer, not always, but almost always, there's inflammation. That's the report. It says, inflammation, right? So I think that's contributing to prostate problems, and BPH, I think, is confused with BPH. And what we're trying to, a very important part here, Evelyn, is the following. I don't necessarily care how big the prostate is. So a normal sized prostate is about 20 grams. 20 grams is about the size of a walnut.
That's it.
Prostates can grow into the size of a mandarin, a golf ball, a mandarin, an orange, and sometimes even a small grapefruit, right? A small grapefruit is, 350 grams. That's a big size. What you're trying to avoid by treating the prostate is not just lowering the size of the prostate. And this is why I have an issue with 5-alpha reductase inhibitors, the ones that stop the DHT, because you're lowering the size of the prostate. Great. Most of those men still have urinary issues. What you're trying to avoid is urinary issues that are associated with the prostate. What you're trying to avoid is the squeezing of the middle, right, that surrounds that what's called a transitional zone of the prostate that squeezes the urethra. That's what you're trying to avoid. So you can have a 30-gram prostate, not big, with urinary issues that are associated with the prostate. You can have a 200-gram prostate, small orange, no urinary issues. So the goal is not to just shrink the prostate. The goal is to relieve from urinary issues. So that's the conversation to have. It's oftentimes confused. It confuses what the goal is. The goal is not just to decrease the size. The goal is to open up the transitional zone so that the person can pee better. So that's my focus, as opposed to, hey, let's just give them a lot of saw palmetto and maybe it reduces the size of the prostate a little bit with a little bit of 5-alpha reductase inhibiting action. And then that's not the goal.
Thank you for all those distinctions. I want to talk more about, excess peeing, and especially at nighttime. I know that's a big problem for people. And I have actually seen the few times that I've recommended it, I don't work with men a lot, but the few times that I have recommended flower pollen extract, specifically Graminex, the trademarked one, I was able to have people achieve dramatic improvements in a really short period of time, especially with that excessive nighttime peeing in literally days, like 2 days. I don't know if that's common. I know the studies say more like, 12 to 24 weeks, but I was curious what your experience is with that ingredient specifically, because I think it's amazing.
So it is an amazing ingredient that I use quite often. The question is, why is this person peeing a lot at night? Are they peeing a lot at night because of the prostate issue that we were talking about earlier? It's an actual issue. Are they peeing a lot at night because they're not sleeping? So there's an association with things like sleep apnea and nocturia. And what they find is that it's not a urological issue, it's a sleep issue. Right? So you got to ask the question, what comes first?
Yeah.
Do you feel that you're in a deep sleep, very deep sleep, and the feeling of having to urinate wakes you up to go pee? Or do you feel like, yeah, you're not really in a deep sleep, you're kind of half asleep, and you're saying, okay, let me go pee because I don't have the urge. I sleep very well, right? All the time. If I'm not sleeping well for whatever reason, then I'm going to go pee at night, right? So what comes first is a very important question. Maybe treat the sleep. Maybe see why they're not sleeping well. Maybe see, treat their stress and figure that out. Like, that's the issue. Also, remember, the reason why we're saying prostate in a urinary scenario with men is because they have a prostate. So you kind of blame the organ you have. You wouldn't tell a woman with nocturia, hey, you have a prostate problem. Men also have bladders.
Yeah.
So they have overactive bladder just like women. So the issue that I find is that oftentimes that when men have LUTs, right, lower urinary tract symptoms, or is the prostate, they treat the prostate. Well, it doesn't have to be the prostate. It could be overactive bladder. In fact, oftentimes it is overactive bladder. So that's what you want to treat. So back to your questions, because I can digress, as you can see, but bring it back, is nocturia. If it is so Graminex, right, pollen extract works really well. Quercetin, excellent. You got a lot of bang for your buck with quercetin. And this is just supplements, right? Just behavioral things that we could talk about. Inflammatone. I'll say it. Inflammatone. It is a really, even for BPH, because there's oftentimes, again, it's not BPH, it's like inflammation and other things. Magnesium, right? What are we trying to do? We're trying to calm the system, the overactive bladder, the overactiveness of the pelvic area. So magnesium is an excellent to give at night, 3 hours before bedtime. whether it's glycinate or, I'm not exactly sure what form works best. I use a bunch, actually. I do use glycinate and citrate and malate. And sometimes I use, a few at night because I don't know which one is working. So since I don't know, for this particular purpose, that is, and certainly they have constipation. That's the other thing, very important. It's great because sometimes you do get to see in science that, wow, naturopathic medicine always had it right. The digestive system, wow, treat the colon. Wow, there is evidence that show that men who suffer more from constipation and IBS tend to have more urinary problems and prostatitis. So you got to treat that. If that's the case, I do give them magnesium oxide and citrate so that get bowel movements in place and also perhaps some benefit from the magnesium.
Yeah. Thank you so much for that answer. You caught me going green pharmacy there instead of asking what the underlying reason is. It's easy to do in our profession.
Correct. And you always want to look, even with a guy that comes in with erectile dysfunction. Hey, are there any PD5 inhibitors? Well, listen, first, if you're coming to see me, did you read me up online? Because I'm trying to help you with the cause. If not, look, the urologist down here, he'll get, right? So, and I don't have a problem with PD5 inhibitors. I get it. And I'm a man and I get it. It's a Band-Aid. Why are you not getting erections normally?
Yeah.
The penis is a barometer to a man's health. So let's look a little bit more deeply. Sure. I don't know, it's your anniversary tonight or whatever, new girlfriend, no problem. New boyfriend, I don't care. Great, tonight. But don't be dependent and let's figure out the cause. So you got to look at what's really happening at a deeper level.
Yeah. And we could do a whole show about erectile dysfunction. We have talked about it on the podcast before, but I do want to go back just to a few more nutraceuticals, because that is one of the things we love to talk about on the show, but specifically things like nettle root, cranberry, pomegranate. I have a note here. I think it's from my herbal medicine notes that it delays the doubling time of PSA. And like zinc and selenium, like just how those fit into BPH or prostatitis.
So I will say yes to all. So cranberry extract has shown to help men in a study, randomized, I believe, to help men lower their LUTs pretty significant. So cranberry extract. So yes, right? Pomegranate extract. Absolutely. There's a lot of benefit there. The study that showed that lower PSA had broccoli extract, pomegranate, two others. I want to say green tea and curcumin. Those are the four, I want to say. And it was a formula that had those four. So all those things are good for sure. Selenium is a very important mineral for the prostate as well. So I would say if I had to rank them, which is shouldn't do, but I'll do it anyway. Zinc is number one, and perhaps selenium is number two.
Wonderful. Well, Geo, I think we did it. I think we crammed a whole semester into one episode.
Right. Exactly.
We may have to do a part two. Somehow we did it. We do have a few questions that we ask everybody on the show, just rapid fire. If you can, what is something that you've changed your mind about in all your years of practice? Maybe the most significant thing.
That in the field of urology, which is what I know most, medicine works really well when needed, and urologists do amazing jobs when someone needs a medical intervention. Because your naturopath function, everything, medicine is bad, medicine is bad, medicine is bad. I took time to know when is it bad. And yeah, that's why I think natural approaches work very well in urological functions for sure. But when is it good?
Yeah.
I don't want to say, I don't care about my bias or anything. My patients don't care about my bias. No. When do I need an intervention that actually will help my quality of life or save my life? And there are those situations in medicine. And if there's one takeaway for the audience is don't be closed-minded. I know the problems in medicine. You do too. When is it good? Change the mindset. When is it good? When is it good when by itself? When is it good integratively as well? That's the question to ask. We all know the issues, but when is it good and helpful? Yeah, that's
Absolutely. Thank you. And what are your 3 favorite supplements for yourself? Like not brands but the 3 top things that you take.
So I would say curcumin.
Mhm.
I believe that lowering my inflammation as I get older is important. I would say ashwagandha. And those are, I'm just going to stick to botanicals for now, right?
Yeah.
Ashwagandha, curcumin. I would say maybe cordyceps.
Nice.
Yeah.
Great.
Cordyceps is also good for testosterone, by the way.
And what are your favorite health practices that you do to keep you healthy and resilient?
Weight resistant exercise and sleep. Those are the 2 things that I believe, and the supplements I take.
Yeah.
My diet sometimes can be better. I have kids, so I eat whatever they leave on their plate, regardless of what it is, just to not throw food away. But I would say weight resistant exercise and a lot of movement, I would say. And I don't play with sleep. Once it's time to go to sleep, just stay out of my way. So
good. Well, Geo, thank you so much. This has been such an insightful conversation. I learned so much, and all the clinical pearls that you shared. And again, your contagious enthusiasm for all of these topics. So thank you.
It's completely my pleasure. And I love Designs for Health. I really do. Been for a while. Been a fan for a long time.
Well, thank you for tuning in to Conversations for Health today. Check out the show notes for resources from today's conversation. Please share this podcast with your colleagues, follow, rate, or leave a review wherever you listen or watch. And thank you for designing a well world with us.
This is Conversations for Health with Evelyn Lambrecht, dedicated to engaging discussions with industry experts, exploring evidence-based, cutting-edge research, and practical tips.